When I thought we would do the ACA as our theme today, I thought we ought to check with the Cleveland Clinic, since the Cleveland Clinic is a big part of the consortium. And I did it. I don't know Dr. David Longworth personally, as I do Jean Dubois and Tim Jost. But I do have a little story to tell about this that tells you a little bit about Dr. Longworth's expertise and what he brings to us today. So I wrote to people whom I do know at the Cleveland Clinic, Alan Hall, Dr. Alan Hall, and Dr. Jim Young. Who would be a good person at the Cleveland Clinic to talk to us about the ACA and poverty? Well, I not only got the same answer, and the only answer they gave me, but I got a resounding answer. Said, you need to talk with Dr. David Longworth and invite him to come to your symposium. So we did. What we're going to get here, as I imagine it, and I'm pretty confident about this, is a nice complement to the leading scholar on healthcare law, because David focuses on delivery and health care that goes beyond simply access and providers and the policy, although he's very knowledgeable about the policy as well. I'm confident that his title as Chief of Staff of Clinical Integration Development helps him to understand the focus of his talk on healthcare delivery, and I'll let him specify more the connection between his work at the Cleveland Clinic and the implications of what he has to say for the Affordable Care Act on care delivery to low-income Americans. I don't want to spend a lot of time introducing Dr. Longworth, just as I did in the other speakers. You've got the bio, please read it. I will say that a little bit about his early education. He graduated from a fairly reputable institution in Williamstown, Massachusetts. And he stayed northeast for his medical education at Cornell. As a specialist in infectious diseases, David has studied and practiced medicine at a variety of well-known institutions, including a stint in San Francisco. He returned to the Cleveland Clinic in 2011 to chair the Medical Institute there. Our interns, who work directly in health services and public health, and with those clients and members and consumers that rely on their clinics, know that and have discovered this summer that health care for low-income individuals and families extends beyond this prescription pad, as one of my students once put it. For that reason, we are privileged that Dr. David Longworth is here to talk to us about the difference the Affordable Care Act makes for the delivery of health care services and this cohort of our nation's citizens. David, thank you.
Well, good morning, everyone. One of the privileges of the practice of medicine is that you meet people from all walks of life. You meet them in their most vulnerable moments. You meet them in the grocery store. You meet people that you never expect to meet. And today it's a gift for me to be able to meet you and to be here to talk about the implications of the Affordable Care Act in thinking about how we fundamentally redesign the care delivery system. Before I launch in, I just want to make a couple of comments. First, it's a real privilege to share the podium with Professor Jost. You have received a remarkable gift today. I've been hearing people speak about the Affordable Care Act now for several years. Today's comments by Professor Jost were remarkable. The most highly nuanced, sophisticated, and comprehensive discussion of that law that I have heard. And I would encourage you to download that talk and to save it for future reference. So thank you very much, Professor Jost, for those comments. I do think I had not seen your notes before. I do think we will line up and say some of the same things. I am not a lawyer. I am not a policymaker. I come to this work through the lens of a physician. My story is that I have been a practicing internist and an infectious disease physician for over 30 years. I joined the Cleveland Clinic in 1986 as a young faculty member as an infectious disease specialist, became chair of the Department of Infectious Disease in 1992, served in that role for a decade, and left. I believe in term limits in healthcare leadership positions. And I moved to Massachusetts as the chair of medicine in a 3-hospital system based in Springfield, Massachusetts, one of the poorest cities in the Commonwealth that went bankrupt on my watch as chair of medicine. And we, at the time, watched the rollout of Romney Care, which was the harbinger of Obamacare. And we saw 20% of our populace in Springfield who were uninsured gain Medicaid, struggle to have access to fundamental primary care and behavioral health services. But we brought them in and began to care for them. And then I was recruited back to the clinic in 2011 to help develop and execute their healthcare reform strategy, a privileged job. I get to think about how to deliver care better for people from all walks of life across the continuum in an elite organization, and that is a profound and wonderful privilege for me that I just need to acknowledge. I will step out of my institutional role for a moment and speak very personally. I support reform. I believe that healthcare is a fundamental human right. Many countries across the world have recognized that and provide that care to patients irrespective of their ability to pay. And for me, it's a personal shame that we don't do that in this country for people who are impoverished and don't get access to care. So I do support reform, and I've come to this work with that perspective. And finally, as is in the custom of most medical talks, I have to comment on my disclosures around competing relationships. I have none. No disclosures to make. I've been squeaky clean my entire professional career around relationships with pharmaceutical companies and others. So I have no disclosures to make, and what I'm going to say today is informed by my own understanding and interpretation of the law and what I think we need to do around redesigning healthcare delivery and what our institution at the Cleveland Clinic is doing as well. So I want to talk about 4 basic areas today. I want to talk about how I see the state of healthcare delivery today. I want to talk about the provider's perspective of the Patient Protection and Affordable Care Act and the move to what we call value-based care. And we'll talk about that whole concept of value because you're going to hear more about it if you haven't already heard about it. I want to talk specifically about the healthcare challenges in poverty and the challenges that those pose to us thinking about how to redesign care delivery to facilitate access to care and continuity of care for those who live in poverty. And finally, I want to think about what that means on a day-to-day basis in thinking about redesigning the care delivery model. So, healthcare delivery today. We spend a lot on healthcare in the United States. These are data from the Kaiser Family Foundation, published in about 2011, looking at 2008 data, looking at total health expenditures per capita. What's that mean? How much we spend per life on an annual basis, comparing the United States in orange on the far right with about 15 countries in the developed world in blue. And I think it's striking to note that we spend per life anywhere from 1.5 times to 3 times the amount that other countries in the developed world spend on health care for their population. And this trend has steadily increased over time. These data from the Congressional Budget Office showing that in 2007, we spent about $2.1 trillion, or about 16.3% of our gross domestic product, and that trend has steadily increased so that unabated in our healthcare expenditures, we will spend approximately $4.3 trillion in 2017, or 19.5% of our gross domestic product. I would argue that that is unsustainable. And to quote Michael Levitt, a Republican, the Secretary of Health and Human Services under Bush, the second Bush, we face an economic tsunami around health care, not only in the United States, but in the world. And if this trend continues unabated, if this trend continues, it will bankrupt us as a country and you as a generation moving forward. So we must figure out how to do this better for all of our population, and how to do it better and to rein in escalating healthcare costs. Despite the fact we spend more on healthcare than any country in the world, that money doesn't buy us better healthcare. And these are data from the Commonwealth Fund that look at a whole variety of different metrics: quality of care, access to care, efficiency of care, equity of care, longevity, life expectancy, and healthcare expenditures, and compares performance among 7 industrialized countries on the top, whose flags are depicted. The best performers are in green. The medium performers are in yellow, and the worst performers in these domains are in red. And if you turn your attention to the far right column underneath the United States flag, we are red in every domain but 2. And in those 2, those being effectiveness and patient-centeredness, we're in the middle of the pack. We have no green in our column. And so despite the fact that we spend more on care than any country in the world, that doesn't translate into better care for our population. I'm not going to ask for a show of hands, but I would guess that many of you in the audience, like me, have tried to navigate health care for loved ones, friends, and family with serious illness. Even for a sophisticated consumer like me, who is medically nuanced, understanding, can pull strings, knows who the best providers are, it's tough. In today's world, care is fragmented. It's variable. It's highly discontinuous. We don't do handoffs well. When patients move from one venue of care to another, we often don't know it. We have trouble coordinating care for patients with complex, chronic diseases over time. And that's especially true for those living in poverty. Moreover, as we've heard, access to care is inconsistent. 57 million Americans are uninsured. As Professor Jost noted, the Supreme Court struck down the mandate, though allowed for expansion. 7 million signed up on the exchanges and have paid their first premium. As noted, another million probably have signed up as well. There's been some challenge in the courts to the federal subsidies. I'm going to be interested in Professor Jost's comments during the Q&A about where he sees this headed. I hope that as a naive doctor, my cautious optimism is not unfounded in terms of us getting there. And as noted, and I made this slide about a month ago, the percentage of uninsured has fallen from 18% to 15.6%, and you commented 13.5% or 13.4% over the past 6 months, the lowest percentage of uninsured Americans since those data have been collected by the Gallup Foundation. And yet, despite the attempt to enroll more Americans, access to care is likely to remain inconsistent and incomplete over time. And this is a somewhat busy slide that was released in February of 2014 by the Congressional Budget Office, projecting out what is likely to happen in 2024 after 10 years of full implementation and nearly $2 trillion in expenditures with regard to insurance. And the bottom line is that it is projected that 31 million people will likely remain uninsured, and those who do gain coverage will do so primarily through exchanges or through Medicaid. And the details are summarized in the different bars, but I think the point that I want to make is that, as was stated by Professor Jost, the Patient Protection and Affordable Care Act is an important step forward for patients living in poverty, but it is not a panacea, and it will not insure every American in the United States moving forward, at least as projected today. And so with that as preamble, and hopefully an overview of how I, as a provider, see healthcare delivery today, I want to talk about how we in the healthcare industry have interpreted the law and have begun to transform care delivery in response to the law. Healthcare is changing dramatically in the United States today. I've been at this work since graduating medical school in 1978. I'm in my 36th year. And I have not lived through such a profoundly transformational change in healthcare in my entire professional career. In the 1990s, the Clintons tried to transform healthcare, and they largely failed. And as I look at it from a provider's perspective, I think they failed because it was all about rationing. It was all about denying care. There was no real thought given to how to transform the care delivery model, how to leverage healthcare information technologies and electronic health records, how to create incentives that really drove quality and tried to lower cost. And they failed. For me, this time around feels a little bit different. And I think there are real pressures out there that are challenging us in the healthcare industry to think fundamentally differently about how we're going to deliver care. What are those challenges? Well, we have an aging demographic. I'm 61, about to be 62. The boomers are coming at us in healthcare, and we're going to cost a lot. Moreover, as commented on, we have a large cadre of uninsured people in this country, and many of those people have chronic diseases that have not been attended to, and unless we do and take care of them up front, we will pay for their care later moving forward. I've talked about the economic challenges in healthcare, the rising expenditures that threaten to bankrupt us as a nation. Technology is more and more a part of healthcare. We have big appetites for technology in this country. We like the newest gizmo, gadget, or drug. They're expensive. And we like them, whether they're indicated or not, whether they really improve quality of life in a meaningful way. And that's a challenge for us as we think about how to rein in healthcare costs and deliver appropriate care to everyone in our society. Moreover, there is more and more transparency in our industry about how we as providers and as health systems perform around quality and cost. And one of the challenges for us at the Cleveland Clinic, despite our incredible reputation and brand recognition, is that the cost of our care is way too high. And the quality of our outcomes is not consistently excellent. And so we, like other industries, systems, have major challenges given the fact that our outcomes and results are publicly reported and available to consumers, payers, and employers. And so there's a real urgency for us at the Cleveland Clinic, and I would argue as an industry, that we need to take back and drive the discussion and plan or be planned for. So as I look as a naive doctor, and we heard an incredibly nuanced discussion about this, I think that the Patient Protection and Affordable Care Act tried to do a couple of fundamental things. First, it was about insurance reform and expansion of coverage, to provide insurance for more people and to provide better coverage. And I will be interested in Dr. Jost's response to this comment, but I think that the legislation has not been completely successful in this regard. I think it's a step forward, but it has not been completely successful. But it also began to challenge the healthcare industry to think about care delivery reform, to provide more highly integrated care for all populations, to focus increasingly on quality, and to innovate around the care delivery model. And in this regard, I think the Patient Protection and Affordable Care Act has been a home run. We in the industry would not be having the serious discussions that we are having today about how to improve quality and take cost out of the system and facilitate access had it not been for this piece of legislation. We would have been business as usual, fee for service, doing everything we could to ramp up volume, not thinking about how to keep people out of hospitals and emergency rooms when they didn't need to be there, not thinking about how to prevent readmissions to hospitals that should have been prevented because we got paid for those readmissions and we get paid for them today. This piece of legislation is a game changer in forcing healthcare systems to fundamentally think about how to redesign the care delivery model. Beginning in about 1999, the Institute of Medicine published a series of landmark monographs, this one in 2001, called Crossing the Quality Chasm, highlighting the profound challenges that we in healthcare at that time, and which we continue to face today, face in providing care that is safe, effective, patient-centered, timely, efficient, and equitable, not just for insured Americans, but for all Americans. And I think this remains a profound challenge for us today, which the Patient Protection and Affordable Care Act has brought into sharp focus for us in the industry. Donald Berwick is a pediatrician and the founder of the Institute for Healthcare Improvement, a think tank in Cambridge, Massachusetts in the early 1990s. I wonder how many people in the audience have heard of Donald Berwick. Oh, just a couple of hands going up. I ask this question of medical students, medical residents, and young faculty when I talk on this topic, and it's disappointing to me how few hands go up. Donald Berwick, in my estimation, is a visionary physician, and history, I think, will look back and recognize him as a transformative figure in healthcare in our time, because for 20 years, he's been driving quality, patient safety. He was the interim director of Medicare and Medicaid services. The Republicans blocked his confirmation, and he stepped out of that role, succeeded by Marilyn Taverner, and is now running for the governorship in the state of Massachusetts. But Don really proposed the three-part aim, which in fact in many ways is core to what the Patient Protection and Affordable Care Act is all about, and that is better care for individuals, better health for populations, and lower growth in healthcare expenditures. To sum up for me, as I talk to medical students and residents about it, this is the core of the matter, how we will do this work in our country for individual patients, for populations, driving quality, taking cost out of the system. Michael Porter is a professor of business at Harvard Medical School who, beginning in 2006, began to write about the whole concept of value. And he defined value as the algebraic equation of quality over cost. So, hearkening back to your high school algebra, you can improve quality or value by improving quality and maintaining cost, by maintaining quality or lowering cost in the denominator, or aspirationally by improving quality and delivering the care at lower cost. This is not a new concept. And this concept has come to other industries long before it came to healthcare, the aviation industry, the IT industry, the banking industry. But we in healthcare have only recently begun to think about how to drive value. And the Patient Protection and Affordable Care Act, through our lens, is all about driving value of healthcare. At the Cleveland Clinic, this concept has become the core of our strategy as we think about redesigning care delivery in both primary care and specialty care for all populations of patients we serve. And we know that while we have to improve quality, we have to take cost out of the system. In the old world, which continues today, it's the fee-for-service world. It's been all about the care of the individual reactively. We've gotten paid for any service we provide, whether it's indicated or not, whether we do it well or not. And there's been a wonderful predictability to that market, and lots of healthcare systems, including us, have really ridden that horse and been highly successful in that old world. But the new today is quickly moving to a value-based model, where we will be challenged to care for populations, where our payment will be not based on every widget of work we do, but on our quality and our efficiency, and we will need to take risk that if we don't deliver that, we won't get paid. And that is happening today as we and others across the country are negotiating contracts with payers and employers. So I think that's our perspective. There is profound pressure in the healthcare industry to change and to change quickly in response to the Patient Protection and Affordable Care Act. And so I want to move on and talk about the healthcare challenges in poverty and then how I think about redesigning the care delivery model. These are the sobering statistics. Professor Jost alluded to some of these in his remarks. 50 million Americans are estimated to live in poverty. And there is disparity with regard to underlying disease prevalence. Compared with those not in poverty, there is nearly a twofold higher number of patients with depression who live in poverty. 31.9% are based upon Gallup data from 2011 that were released a year or two ago. If you look at the dual eligible population, the elderly poor, those who qualify for Medicare and Medicaid, in many states, over 50% of them have significant behavioral health issues, depression, schizophrenia, other types of mental illness. And a lesson learned in our industry is that if you don't deal with the mental illness, you can't address the underlying medical problems. And so that has profound implications for us thinking about how you deliver care, because we've got to provide appropriate, accessible behavioral health support to a very challenged population before we can even begin to think about addressing their chronic diseases, and at a time when we as a country in many states, I saw it in Massachusetts, it's true in Ohio, where we've gutted behavioral health services, where we have not reimbursed for it, where it's really tough for patients who are insured by commercial payers, let alone patients who are uninsured or on Medicaid, to gain access to basic behavioral health services. There's a higher incidence of asthma, obesity, look at that number, 32%, diabetes, hypertension, heart attack, about similar rates of cancer and high cholesterol if you live in poverty compared to not living in poverty. These are what percentage of individual patients have one of these. If you roll them up, more than 50% of patients have at least one of these, and many, many patients living in poverty have multiple conditions. If you have obesity, there's a fair chance you're going to have type 2 diabetes and hypertension. There's a fair chance you may have high cholesterol. So people don't often have just one of these. They have many of these diseases when they live in poverty. And there are particular and unique challenges in caring for people living in poverty from the provider standpoint. First is basic access to services. We heard that if you have a high deductible plan, or even a reasonable deductible plan in the eyes of some more affluent people, those deductibles may be major challenges and out of reach that make people in poverty choose not to seek health care, especially routine health care or preventive health care or health care that addresses their silent chronic diseases that may not make them feel sick, their obesity, their diabetes, their hypertension, their high cholesterol. Those are often silent diseases that people don't know they have. And if they don't come to the doctor, they may not have those recognized, and if they don't have those recognized, then they are at a much higher risk for morbid complications down the line, heart attack, stroke. So basic access to services is a problem. We've heard that some caregivers do not accept Medicaid patients. There is a shortage of primary care physicians across this country. There is a shortage, but equally importantly, there is a profound maldistribution of where those primary care providers are, with rural areas particularly challenged with regard to access to primary care services in many parts of the country. In Massachusetts, when Romney Care rolled out, We saw an infusion of a large number of previously uninsured patients in Springfield into our primary care base. They had previously been using our emergency room for episodic care, for acute problems. And then those patients overwhelmed our primary care base initially, and we struggled, ultimately got them in, and began to do chronic disease management. But access to services is a challenge in many parts of this country. I've commented on the significant behavioral health burden in this population and the lack of services in many parts of this country to address that very, very real need. And believe it or not, at the Cleveland Clinic, we have that problem too. You would think we wouldn't. But in our primary care practices for all patients, not just uninsured or Medicaid patients, we find it tough to get timely access to behavioral health services at our place and in our community. Health literacy, being able to understand basic healthcare terminology, diseases, is a challenge across our country, but a particular challenge for those living in poverty. I've talked about patient engagement in chronic disease management and wellness. Patient engagement, what does that term mean? That term means the ability and confidence of an individual to understand his or her medical problems, medications, and to feel equipped to manage them, to make informed decisions about their medical care, where they are active participants in their care and not passive recipients in care. There have been a number of surveys conducted in recent years about patient engagement across the country, irrespective of payer, and fewer than 25% of individuals in the United States today feel confident that they have the tools that they need to make informed, intelligent decisions about their health care. That's a profound challenge for us in the industry about how to better equip and educate patients around the choices they make, and that's a particular challenge for those living in poverty. Stigmatization. A number of studies in the medical literature commenting on the perception by those living in poverty and on Medicaid that they are stigmatized in the eyes of providers. They're afraid to tell their caregivers the truth. They're afraid to tell them that they haven't filled their scripts, or that they're cutting their pills in half to make them last longer, or that they're not taking the medications as instructed because they feel stigmatized. They are afraid they will be judged by their caregivers. And so that is a real challenge for us as caregivers, to be aware of that, to be sensitive to it, to respond to it in a non-judgmental and supportive and caring way, and to educate the next generation of caregivers around those nuanced issues, around emotional intelligence, empathy, sensitivity. Adherence to medications, we've heard about it. Many reasons why people don't take their medications from all walks of life. Transportation. Lots of people simply can't get to the caregiver. In Cleveland, we do have transportation systems in place. Medicaid funds some of them. That service is available, but in my own personal experience, doesn't work well for a lot of people. And so for some of our family health centers, we've actually begun to have our own transportation systems where we can go out and pull people into their appointments. Why do we do that? It's the right thing to do. We'd rather people have a relationship with a primary caregiver over time, develop that relationship, and not at 11 o'clock at night decide they're going to an emergency room, where a whole lot of bad things can happen in terms of appropriateness of testing, resource utilization, inappropriate treatment in the moment. So transportation is a challenge. We've heard about dental services and vision services. That's a challenge in many parts of the country for these individuals. Nutrition support. We don't have enough nutrition support for any of our patients, but especially for those who live in poverty. Caregiver emotional intelligence and empathy. Those are not skills that my generation was taught in medical school. And as I speak to people around the country, these are skills that only a very few medical schools are beginning to teach, but they are vitally important. I'm so proud that we're beginning to teach these skills at the Cleveland Clinic. Why are they important? Well, certainly they're important because they're the right thing to do. You want your doctor to be emotionally intelligent, to be empathetic. You don't want your doctor to be under the pressure of the 7-minute visit. where he or she is not in the moment with you, attentive to your very personal needs, as opposed to staring into the computer. So caregiver emotional intelligence and empathy are important because they're the right thing to do, but really interestingly, there are now emerging data in our literature that the most empathic physicians happen to have the best outcomes in their patients. Better diabetic control, better blood pressure control, better lipid control. So not only is it the right thing to do, but it leads to better health care outcomes. And so with that, as my commentary on the healthcare challenges and poverty, I want to think about how we have processed all of this information and thought about it as we begun to think about redesigning the care delivery model. As I mentioned before, value-based care has become central to our strategy at the Cleveland Clinic. Remember value, the algebraic equation of quality over cost, higher quality at lower cost. We've been at work on this for about 2.5 years, and this is the graphic that symbolizes our new model of care that we call the Cleveland Clinic Integrated Care Model. What does this mean? Well, I like to think about that blue band called the care system as the care delivery highway, the way that patients navigate the healthcare delivery system from one point to another, from one venue to another. And I would argue that today, for most patients, that care delivery highway is a dirt road, one lane, filled with potholes. Those on and off ramps from different sites of care, the emergency room, to the clinic, to home, to the hospital, to rehab, to nursing homes, we don't do that well. We don't talk to one another when patients move from one site to another. And not surprisingly, when we don't talk to one another, stuff happens. Errors get made. The wrong medications get given. Inappropriate tests get done. Tests get repeated. We have a low threshold, if somebody's out there, to send them to the emergency room rather than to try to link them up with the people whom they know at the time that they need to be seen. So we need to rethink how we deliver care across the continuum so that we make it easy for patients to jump on. One way is through an electronic health record like Write My Chart, but have patients jump onto the highway in the moment when they need it to have care delivered at the right time, at the right place, by the right person, at the most affordable cost, at the highest quality. So what does that mean? How have we translated that model into thinking about the work that needs to be done? Well, there are a number of core elements to the Cleveland Clinic Integrated Care Model. The first is something called care paths. A lot of industries have learned that the extent to which you can standardize processes across an industry leads to higher quality and takes cost out of the system. Toyota was an early champion of this. They sort of got into trouble, but they still nevertheless were an early champion of elimination of unnecessary variation, which drove quality and lower cost. And we're late to come to this in healthcare, but this is what the development of care paths is all about. So what is a care path? A care path is a multidisciplinary approach to care where we decide how we're going to treat a disease or a procedure across the entire continuum of care, from the ambulatory clinic to the hospital, to the post-acute services, skilled nursing facilities or nursing homes, to home. One process of care. Practically speaking, what does that mean? Let me give you an example. For somebody who comes in for a knee replacement or a hip replacement, there is great variability in the preoperative testing, in the use of imaging, that is x-rays, in the choice of a joint implant by orthopedic surgeons. And those choices that individual providers make are generally without any evidence behind them. It's based on custom. My goodness, isn't that a scary proposition for those of you who don't do healthcare? But it's true. And so the extent to which we can standardize and provide appropriate care based upon the evidence will take enormous variability, inappropriate cost out of the system. And we're doing that work in a whole variety of different diseases at the Cleveland Clinic. I've given you one, and we have results now that, in fact, by developing care paths for total hip and total knee, for how we manage acute back pain, by how we manage pediatric head trauma, and so forth, that we can drive quality and lower cost. So the development of standardization is one part of the model. Now, that's not to say that medicine will become cookbook. Care paths won't apply to everyone, but they'll apply to a lot of people, and they can help to improve quality and lower costs, and we have evidence to show that. The second element of the model is to develop a program around care coordination where we identify high-risk patients and we manage them proactively, not reactively, but proactively across the continuum. We'll come back to that because that is especially important as a tactic in patients in poverty. Access and flow. When you call your doctor, those of you who have a private physician probably have a local answering service, often in the office that takes your call. For those of you who see providers in a health system, there's often a centralized access call center. And I think we don't do very well at getting patients in when they need to be seen, and as we think about this at the clinic, we're thinking a lot about timely access. Today, Alan Hull's in the audience, a member of the Medicine Institute, knows that a third of today's visits in the Medicine Institute will be same-day visits for patients who call in and need to be seen. That's a step in the right direction. Alan also knows that many of those patients will not see his or her individual provider. We need to get there, and we're working on that. But figuring out how to get people in when they see them, need to be seen, seems obvious that we need to do that. But we don't do that well at the Cleveland Clinic, and we certainly don't do that well across the country, and that has profound implications about how dollars get spent and about how care gets delivered or doesn't get delivered. We need to leverage enabling capabilities such as electronic health records and health information technology to better deliver the care. We don't have a single electronic health record in this country. I wish we did. It would make our lives a whole lot easier. If you go into a clinic at one city in the Netherlands today, they can pull you up. If you travel 75 miles to another city, they can pull you up. That's a huge asset. It leads to elimination of unnecessary diagnostic testing and duplication. We need something called predictive analytics. What's that mean? That means the ability for me to predict how an individual patient and populations of patients will perform over time in the future, as opposed to looking back at how my providers have performed in the past. So to be very, very specific, what does that mean for me in daily clinical practice? If I have a patient with heart failure who comes into the office, she has some kidney disease, she's eaten chips and a lot of salt the last few days, her weight's up 5 pounds. In the old world, I might give her a water pill to make her pee off the extra fluid and send her out and say, I'll see you in a couple of months. In the new world, I need data that pops up in the moment in my computer screen that says, looking at 30 million patients and analyzing the subset that look like Mrs. Smith with regard to her demographics and her underlying medical conditions and where she is with regard to her heart failure and kidney disease, she's got a 50% chance of being hospitalized over the next 48 hours unless you do something different. Whoa. That would be a different way of practicing medicine, of identifying high-risk patients. And that may seem like a pipe dream, but that pipe dream is coming. And that pipe dream will probably exist near the end of my professional career, and it certainly will exist for those young caregivers that we are training now. People and teams. Medicine is becoming a team sport, not just about doctors, all about patients, patient-centeredness. We need to figure out how to build teams around patients and populations to meet their needs when they need to be met, and that's especially true for patients living in poverty. So this is all about transforming clinical care. This is what's different today than what happened under the Clintons. We need to move to team-based care. We need to reward added value with sustainable payment models, and we need to support the work with predictive analytics. So, what happens today when you walk in to see your doctor? I would wager that your doctor reacts. You walk in with a problem, and he or she takes a history, orders some tests, or not, sends you on your way. You might play phone tag to get a result. And if you do, that's great. And if you need something, you get a follow-up that often is not particularly timely. In the new world, we need to know who the high-risk patients are. If they don't show up to keep their visit, we need to pull them in. We need to make a phone call, figure out what's going on, and get them seen. We need to provide enhanced access when they need to be seen. We need to plan their visits. Rather than having them walk into the room and having me looking at the computer about what's due, what's missing, what the gap of care is, we need someone else to have looked at the computer, planned the visit, and say, she needs a mammogram, a colonoscopy, she needs this blood work, so that I can be in the moment with the patient, emotionally intelligent, empathic, hearing their problems, responding to them, thinking in a nuanced way about how to engage them in their care. Pre-visit planning, that doesn't happen at most places today. I've talked about care paths. We need to focus, as we're thinking about it in the primary care space, on those 10 to 20% of patients who have chronic diseases and consume 80 to 90% of the healthcare spend, and that certainly applies to patients in poverty and on Medicaid. We need to do a much better job at engaging specialists and other providers in the care that we deliver so that we function as a team, and we need to activate and engage patients, teaching them to be active participants in their care rather than passive recipients in their care. Now, those are a whole lot of words, but building programs to do that is hard, but we need to do it as an industry, and we're working on it at the Cleveland Clinic. So this is all about moving to team-based care that often looks like a clinic nurse, a care manager, a clinical pharmacist to focus on those patients who are on a lot of medicines to help them understand why and to be sure that they're taking them, a medical assistant who is doing pre-visit planning to identify gaps in care with the physician or advanced practice nurse as the quarterback, built all around the patient. The whole concept of patient-centered medical home is really critical to the success of this work and thinking about care delivery redesign. So what is it? NCQA, or the National Committee on Quality Assurance, has defined patient-centered medical home as a model of care. What's a model of care? Well, a model of care is how you configure your team and the healthcare resources, where patients have a direct relationship with a provider. Seems obvious. Doesn't happen in healthcare today. Implies accountability and a quarterback who coordinates a cooperative team of healthcare professionals. Notice the word team. Notice the word cooperative. In medicine today, we don't train people around team skills or around cooperation. Medicine has been an individual sport until very, very recently. And so as I think about my role as an educator, this has profound implications for me around curriculum development. New skills that we need to teach, and if time, we'll comment on a couple of those at the end, who take collective responsibility for the care provided to the patient and arranges for appropriate care, that word appropriate, with other qualified providers as needed. Gets rid of that fragmentation, those random bubbles that don't connect. That's the whole goal of patient-centered medical home. It's a concept that was really born in 1967 by the American Academy of Pediatrics and never really caught fire until about 8 years ago, when a number of professional societies embraced it and drove its adoption. There are a number of core competencies. You need to be able to identify and manage populations of patients. That means I need to know who I'm responsible for. That seems like it ought to be obvious, but it's pretty tough to do. And it's really tough to do if you don't have an electronic health record. If I go to a payer today and they say, you're responsible for this panel of patients according to our records, and I look at my list, they line up in 50 to 80% of cases. Wow, that's a real challenge. I need to know who I'm responsible for if I'm going to manage them. We need to be able to provide enhanced access and continuity. We've talked about this. We've got to be able to plan, manage, track, and coordinate care. Plan, manage, track, and coordinate. It's a lot of work. Need an electronic health record. It's particularly a lot of work for those who are impoverished, for those who have many chronic diseases. We need to be able to provide self-care support and community resources for people. That's not something that the healthcare industry has thought a lot about until very recently. And we've got to be able to measure and improve our performance in population management and in individual management. Until recently, improving performance over time by examining our results and looking at our systems of care has not been in the lexicon. The Patient Protection and Affordable Care Act has put this work front and center in the lexicon of the healthcare industry. So, managing high-risk patients. The heart of the matter, and this includes to many living in poverty, is that you've got to know who they are. You've got to be able to proactively manage and coordinate their care. It's all about access, 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 not just 8 to 5, Monday through Friday, but when they need it, after hours and on the weekends and at night. You need to build trust and relationships over time. So many people who come to healthcare distrust the system, distrust doctors. We need to recognize that, be attentive to that, and to build trust over time. You need one team with a dedicated care coordinator if you're going to build relationships and trust over time. You've got to be able to reach out and manage transitions of care. If one of my patients is coming out of the hospital, a high-risk patient for a readmission, I need to know who they are. I need to know when they're coming out, and I need to see them, likely, within 48 hours, to pick up the baton, to be sure that things are right, to be sure they understand the plan of care, are taking their medications, and to be sure that they call me if they have a problem, rather than going back into the emergency room. We need to provide navigation and financial counselor support for patients who are disadvantaged or who don't know how to navigate the system, and this is particularly important for those living in poverty. We live in a system today where there's little economic incentive to do this, and yet we must do this. We need to provide transportation, we talked about that, nutrition support, dental services and vision support, behavioral health support, a major challenge in so many areas, 24/7 access to services, free transportation where feasible, and we need to figure out how to leverage technologies such as distance health and the creation of registries within our electronic health record that enable us to know who we own and to risk stratify them, to know who the really high-risk patients are so that we can target them and be proactively managing them and pulling them in for the care that they need. And we need to think about caregiver training and education of our existing provider base and the next generation of caregivers, and teach them skills that have not been previously taught. Health literacy, how to probe for health literacy, how to pick up on the subtle nuances of the health illiterate, emotional intelligence and empathy. Most of us think or hope that doctors are empathic and emotionally intelligent. That sadly is not the case. We don't teach emotional intelligence and empathic skills in most medical schools in the United States, and we must. Motivational interviewing, how to coach people, to use every touch of the healthcare system as a coaching opportunity. And one tactic is motivational interviewing. Coaching. Teach back. What's teach back? So, at the end of the visit, Mrs. Smith, do you understand what we talked about today and what the plan is? Yes, Mrs. Smith says. Mrs. Smith, can you tell me what you think we agreed to do today? That's teach back. I do a little exercise that I've started doing about 1.5 years ago, where when I see a new patient, I walk into the room and I introduce myself. I look that patient right in the eye. I usually sit down and hear cases sitting down so that I am in the moment with the patient. I'll say, Mrs. Smith, my name is David Longworth, and I'm really glad to see you today. And if you're a visual person, and I can't tell who can read or who cannot, but some people are visual and process better through visual cues than auditory cues, here is my name tag. Here is my name, David Longworth. And so we will go through the visit. And at the end of the visit, I will say to Mrs. Smith, do you remember my name? Fewer than 25% of new patients who I see will remember my name, despite my attempts, my very intentional attempts, which so many providers don't make, to imprint that. And if they can't remember my name, do you think they're going to remember what we talked about at the visit? Do you think they're going to remember their medications and how we talked about taking them? No. We can't assume as caregivers that patients understand and process what we tell them. They're afraid, they're health illiterate, they're inattentive, they're depressed. That's a big challenge for us in thinking about how to redesign the care delivery model. And we need to be sensitive to the unique psychosocial challenges in caring for people living in poverty. We've talked about those before. One thing that a number of caregivers do, especially people like Alan Hull and myself who have gray hair, is that there is that last question as you're getting up to leave, and that is there anything else? And in so many instances, it's the answer at the end of the visit to is there anything else that unlocks the floodgate of what's really on somebody's mind. And so we've begun to think about teaching skills like, is there anything else? Seems simple, but that's a tactic in engaging people in their care that will apply especially to those who are underserved. So we are at the end. This is my closer for any of you who have heard me speak before. Alan, I think you're the only person in the room. I love this quote by Eleanor Roosevelt, the wife of Franklin Delano Roosevelt, the only four-term president of the United States. Eleanor, a physically large, articulate, forthright, opinionated woman at a time when those qualities weren't particularly fashionable. A woman, and this is a matter of public record, so I'm not violating HIPAA, who died at Columbia Presbyterian of miliary tuberculosis, disseminated tuberculosis, a diagnosis missed because presidents' wives never get tuberculosis. In healthcare, we don't leave ourselves open all too often to considering diagnoses that people couldn't have or shouldn't have, and this is a case with Eleanor. Well, Eleanor said many things, and this is one of my favorite: the future belongs to those who believe in the beauty of their dreams. This is a lesson that I learned way too late in life. Dream big, chase your dreams. Our dream at the Cleveland Clinic is to transform healthcare, not just at the Cleveland Clinic, not just in Northeast Ohio, but to create a paradigm for healthcare delivery that can be a foundation for how we think about doing it in this country to make care better for everyone, our entire population. So dream big. I am so inspired by seeing you all here today, committed to the work you're doing around the underserved and the impoverished. Dream big. For me, Jean Dubois last night was just so profoundly inspirational. I knew nothing of her or her work. So profoundly inspirational. My goodness, what value she has brought to the people that she has served. She is a wonderful role model for those of you who want to do this work. The final thing that Eleanor Roosevelt said that I think I've learned way too late in life, and I hope you'll learn at a younger age. Eleanor said, "You must do the thing you think you cannot do." You must do the thing you think you cannot do. Dream big. Change lives. Help the underserved. Help us eliminate poverty in this country. Because the future is all about you, the young people. My time is nearly past, and you all will pick up this work, and I hope will carry it forward, as will my daughter Sarah, a physician in Philadelphia today. So I want to thank you all for the profound privilege of being here, for the opportunity to follow Professor Jost on the podium, a real privilege, sir, and for the opportunity to share with you one person's perspective and one health system's perspective about what this all means in thinking about redesigning the care delivery model. So thank you very much.
David, we're not going to forget your name.
Thank you. I have a badge for anyone who would like to see it.
That's right. I got mine right here. The other thing I do want to say, following your two things. Our daughter, is studying to be a nurse practitioner. I'm going to make sure she gets to hear this talk.
Thank you.
Very soon.
Thank you.
And I want to make sure that all the rest of you can hear Jean's talk, Tim's talk, and David's talk very soon, so you can make use of it, teaching in your courses, whatever, as soon as possible. And we're going to work on that.